Hi everyone! Welcome to Medicine for Dummies. I'm Dr. V. So, in our previous lecture, we went into detail about history taking, examination, and investigation of a patient with pyrexia of unknown origin. Today, we are going into depth about one of the causes for PUO, which is Juvenile Idiopathic Arthritis. Of course, don't forget to like, subscribe, and share, and comment below if you want any other topics covered. So, let's begin. Juvenile idiopathic arthritis is a chronic type of arthritis seen in children. So, juvenile means young or that it is seen in children. Idiopathic is a medical term we use when the cause for the disease is unknown. And arthritis is, of course, inflammation of the joints. So together, it means inflammation of joints in young patients without a cause. Let's consider a case history. An 8-year-old girl presented with fever for 2 months' duration. She had lymphadenopathy, but no other significant examination findings. So, from this history, you can see that this child has a pyrexia of unknown origin because she has a prolonged fever and no apparent diagnosis yet. We assume that preliminary investigations have been done and no significant findings have been yielded. So, one of the possibilities for this patient's condition could be JIA. So, by definition, JIA should occur in children less than 16 years of age, and the arthritis should be chronic, which means it should be persisting for at least 6 weeks or more. And other causes of arthritis should have been excluded, like septic arthritis or arthritis due to other rheumatological conditions like SLE. This condition usually has 2 peaks, one at around 1 to 3 years and the other in the early teenage years, like in this patient. So, when we take JIA, there are about 7 to 8 different types. It's easier to remember them if you classify. We will consider 5 of the types in detail, and this is actually what you need to know for your exams because it can be asked in the viva and it can be asked in MCQs as well. So, JIA is mainly of 3 types: oligoarticular, polyarticular, and systemic onset JIA. So, oligoarticular means that only a few joints are involved. This can be of 2 types: persistent type, which is the commoner one, and the extended type. The polyarticular means a lot of joints are involved, that is, more than 4 joints. This is also twofold, so we have the rheumatoid factor negative one and the rheumatoid factor positive one. Of course, there is only one type of systemic onset JIA. The other types of importance will be considered in a while. So these 5 types given here differ in their onset, sex predominance, joint involvement, extraarticular features, and labs. The oligoarticular persistent type, which is the commonest out of the lot, is usually seen in younger children of 1 to 6 years and mainly in girls. 1 to 4 joints are involved, and these are usually large joints like the knee, ankle, or wrist joint. The important difference between the extended type is that no matter how many months passes with this condition, the involvement is always 4 or less joints. No more joints will be involved. Another very important thing about both the articular types is that it is associated with chronic anterior uveitis, where initially you get a red, angry-looking eye due to inflammation of the front part of the eye. And this is very dangerous because it can lead to blindness. There can also be leg length discrepancy, meaning that one leg may be longer than the other. The cause for this is that due to inflammation of the joint, there will be excessive growth in that limb, causing leg lengthening. These patients usually have a good prognosis but can be ANA positive or negative, where the ANA positive type is the one involved with anterior uveitis. So if the ANA is positive, we take it that there is a worse prognosis than when it is negative. The second type is the extended type of oligoarticular JIA. So the only difference from the persistent type is that even though initially 4 or less joints are involved, after 6 months, more joints can be involved, and this is usually asymmetrical and involves both large and small joints. The rheumatoid factor negative polyarticular type is seen in 16% of identified cases and relatively has a better prognosis than the rheumatoid positive one. It is also seen in children of 1 to 6 years and with symmetrical large and small joint involvement. This can also affect the temporomandibular joint and the fingers. Uveitis is seen in about 5%. The rheumatoid factor positive one has the same features with the addition of other extra-articular features seen in adult rheumatoid arthritis. So you can see rheumatoid nodules like this. And of course, when we do labs, we find the rheumatoid factor to be positive. It is usually seen in teenagers of the age range of 10 to 16 years. Systemic onset JIA is kind of a separate category where you have a lot of extra-articular manifestations. So this is seen in children who are less than 10 years. And the important thing is, unlike the other types, the female to male ratio is 1:1. So it is equally seen in both males and females. You can get either an oligoarticular disease or polyarticular disease, but these patients initially only have muscle aches or joint aches and not inflammation or edema as such. They can have multiple other features like acute illness, fever, serositis like pericarditis, a salmon pink rash like this, lymphadenopathy, or hepatosplenomegaly. There is no specific test for this, but the prognosis is quite poor in these patients. And this is the type of JIA most likely to be present in the case that we considered earlier. So, there are 3 other types of JIA, which are psoriatic arthritis, enthesitis-related arthritis, and undifferentiated arthritis, which is basically where we categorize the cases that don't fall into any other category. So psoriatic arthritis is similar to adult psoriasis, so you can get the typical silvery rash of psoriasis and associated features like dactylitis, which is inflammation of the digits, and Achilles tendinitis, where the Achilles tendon near our ankle can get inflamed and cause pain and difficulty walking. And also nail pitting and onycholysis, where you see small indentations on the nail and the nail can be separated from the nail bed. Enthesitis-related arthritis is where there is inflammation of the place where the tendons or ligaments meet the bone. So this can happen around any joint, and the important thing about this type is that if we do labs, the HLA-B27, which is a type of protein seen on the surface of WBCs, can be elevated. So this is an MCQ point in exams. So now that we know the types of JIA, we need to look for complications. A lot of these don't need to be remembered. We can actually think and brainstorm as well. So, because there is joint damage and subsequent fibrosis of the surrounding structures, these patients can get contractures of the joints. So, the joints will be placed in static positions, and there will be difficulty in moving. Also, we discussed that these patients can get chronic anterior uveitis and serositis, which is inflammation of serous membranes. So as you know, serous membranes are located around your heart, the pleura, the peritoneum, and when these get inflamed, we call it serositis. You can also get restrictive lung disease, where it is difficult for the lungs to expand, and macrophage activation syndrome, which is one of the deadly complications of JIA, mainly systemic onset JIA. You can also have leg length discrepancy due to overgrowth through the growth plate, as I said before, and in some children, growth failure as seen in any chronic condition. Anemia can also be present, and delayed puberty, which is also associated with a lot of chronic conditions. Osteoporosis can be present for one because of the chronic condition itself, and the other due to poor nutrition and reduced mobility. Amyloidosis is a disease characterized by abnormal deposits of amyloid proteins in the body and is a very rare complication of JIA. So, when we consider the management of JIA, you know that it has multi-system involvement, so a multidisciplinary approach is warranted. We must educate the parents, and if the patient is older, the child as well, about the condition and what to expect. Physiotherapy and weight-bearing exercises will help with mobility and to reduce the occurrence of contractures. Because these patients can get osteoporosis, we recommend giving dietary supplements of calcium and vitamin D, and if not, to give high-quality food containing these nutrients like dairy products. We also need to collaborate with ophthalmology if the patient has anterior uveitis. Also with dental specialists, because with temporomandibular involvement, these patients can get difficulty with opening their mouth and brushing teeth, and even speaking, so we have to maintain dental hygiene in these patients. And of course, for associated bone involvement, we might need the input of orthopedic surgeons. We can use some surgical measures like replacement of damaged joints and soft tissue release for people with contractures, but these are not commonly done as we need to address the underlying cause first. The mainstay of management is pharmacological therapy. For pain relief, we can give non-steroidal anti-inflammatory drugs and other simple analgesics like paracetamol. For oligoarticular disease, where only a few joints are involved, and these are mainly large joints, we can give intra-articular corticosteroid injections to reduce inflammation. The main drugs we use to reduce inflammation throughout the body in either oligoarticular or polyarticular disease is a drug class known as DMARDs, which is disease-modifying anti-rheumatic drugs like methotrexate or sulfasalazine. Of course, methotrexate will cause liver damage and bone marrow suppression, so it is important to monitor liver function tests and full blood counts in these patients and to prescribe folic acid as well. Systemic corticosteroids, either given orally or IV, is given as a last resort for conditions which are not controlled by the above drugs, because steroids have an array of side effects, including getting Cushing's syndrome and hyperglycemia. We can also try with biologics, which are monoclonal antibodies, and some examples are given here. For osteoporosis, we can prescribe bisphosphonates, which reduce bone loss. So, that is all about JIA from this video. We went through the classification, complications, and management of the condition, and this video contained almost all the things you can be asked on your exams. So, hope you enjoyed the video, and if you did, please click the thumbs up. Thanks for watching!